Next, we invite Dr. G. Sarmada for presenting on role of OCT in management of benign intracranial hypertension.
Good morning everyone. Today my topic of presentation is role of OCT in management of benign intracranial hypertension. No financial disclosure. Introduction: bilateral optic disc swelling due to increased intracranial pressure with a negative neuroimaging and normal visual acuity and visual field showing enlarged blind spot is diagnosed as a case of benign intracranial hypertension. From the fundus pictures we can see there is bilateral disc swelling. Aim of the study: to study the OCT, ONH and RNFN analysis and GCA in patients of benign intracranial hypertension, to follow up the response to treatment by serial RNFL and GCA scans. Methods and materials: prospective study with sample size 10 who attended a tertiary eye care center on outpatient basis from October 2022 to June 2023. Benign intracranial hypertension cases were followed up with OCT, ONH, RNFL and GCA to determine the response of failure to the medical or surgical management. Here we can see OCT printout analysis in disc edema. Mainly we have to see for neuroretinal rim thickness increase and RNFL thickness increase, and here we can see the RNFL clockers also are showing disc edema. And in GCA, in cases of chronic papillary edema who were not treated on time, they will be resulting in optic atrophy, which can be seen on GCA scans. As coming to the cases, this patient presented to us with raised intracranial symptoms findings, and her BP was normal, and her anterior segment was normal, and posterior segment showed bilateral disc swelling, and her neuroimaging was negative, and optic OCT is showing both RNFL thickness is increased, and on treatment with estrozolamide 250 milligrams QID for 2 months, her disc edema was resolved and her disc remained normal. Coming to the second case, her patient anterior segment was normal. She also presented with raised intracranial signs and symptoms presentation. On taking OCT, RNFL showed higher values, nearly it is approaching 606, and we started the patient on estrozolamide and sent for neuroimaging, which was suggestive of BH, and we immediately referred the patient to neurologist for the opinion on shunt, and her shunt procedure was delayed. This resulted in starting of optic atrophy, and later it was much delayed and patient went into severe convulsions, and later surgery was done. Due to the delayed shunt procedure, secondary optic atrophy ensued in this patient, which can be seen in the fundus and also represented in the GCA. Coming to the third case, this patient is a pregnant female who presented us with bilateral disc edema. She was started on estrozolamide 250 milligrams QID and was taken gynec opinion. MTP was done in this case after usage of Dimox for 2 months. Her disc edema was reduced and GCA was normal. Again she became pregnant and again her disc edema started. She had to undergo MTP, then only her disc edema was subsided. These are the 10 cases before medical management, and this one case which we had given shunt procedure, this case is highlighted here. Coming to the discussion, in optic nerve head analysis, we first sought to measure whole of the neuroretinal rim thickness, but it was difficult to quantify. Then we observed that RNFL thickness was more reliable in assessment of disc edema quantitatively in cases of BAH. Disc edema is only confined to RNFL thickness. In chronic BAH, decrease in GCA is indicative of optic atrophy. OCT, ONH and RNFL and GCA analysis helps us in diagnosing of papillary edema or BAH. Following up of these cases, whether to refer the patient for a shunt procedure, post-shunt to assess the thickness of GCA. From our study, we like to propose that OCT is better adjoint than visual fields in monitoring or management of BAH. Results showed one patient had increased in RNFL thickness in spite of maximum medical therapy, 2 patients had to restart, and rest 7 patients had stable RNFL on medical management. Drawback of the study is this is a small sample size. So conclusion is OCT is non-invasive, patient independent and primary modality in diagnosis, treatment and prognostication of benign intracranial hypertension. OCT, ONH, RNFL and GCA can completely replace the visual fields in evaluation and management of papillary edema. These are my references. Thank you.
Well documented case, but what is your take home message of the second case?
So in that case, actually we had to monitor the RNFL thickness, and while monitoring the RNFL thickness in the second visit when she came, her RNFL thickness was decreasing, and immediately we saw that there is signs of optic atrophy. So immediately this patient could have, we could have saved her eye when correctly she would have gone for shunt procedure in time, then we could have saved her eye.
Take home message. Early treatment is most
Huh,
important.
yes.
Starting on a drugs. What
Yeah.
are the drugs they are used to start?
So we started on acetazolamide 250 milligrams QID, and with that syrup potassium supplementation should be given.
So we can't take it granted these things going to subside. We have to be very, very cautious, inform the patient, otherwise they become blind. So this is the what the most important
Yes, sir.
thing. We can't take it granted. These things will subside by giving one tablet. You have to closely follow it up.
See that we cannot conclude that OCT can replace.
Okay, sir.
We have not done any comparative study to tell anything, and the role is supplementary. So let us not go back with that conclusion.
Okay.
The number two thing is that what is most important is that while the RNFL thickness might remain high, the person will first start losing ganglion cells, so your macular GCL levels will start going to deteriorate. In a monitoring of papilledema, always a person has to look at both RNFL as well as MGCL thickness, and MGCL thickness can be erroneously wrong. So you have to do a separate segmentation in papilledema.
Okay, sir.
So with this you can use.
Okay.
Okay, so it's a important message, but it should be taken with caution with what you have concluded.
Okay, sir. Okay, thank you, sir.
Actually, what sir said is very important. Visual fields are more first line of diagnosing a case of this benign glazed intracranial.
Sir, actually.
No, actually, it is a supplement.
Yeah, okay.
That's it.
Any studies done on this OCT in early diagnosis of papilledema? The papilledema is very subtle, it's very difficult to diagnose whether it's there or not. Does OCT help in that kind of a case?
Yeah,
case
yes, sir.
scenario?
We had one case in our presentation. Like it showed only unilateral papilledema on fundus examination. While we did OCT, it showed RNFL thickness in OCT. That fundus was normal in that case. By that we could have diagnosed that case as BAS.
Okay, thank you.
There are special techniques also in OCT that can be utilized. So maybe in the interest of time we'll move ahead, but there are different technologies in OCT only.